Wow!
MUSC. This is bariatric surgery we're talking about, is that right? Okay.
Yes.
Tell us, or tell the audience, what it is, where it is, its value, where it started, how long we've been doing it here at MUSC.
I've been with MUSC for 10 years. I started as the bariatric surgery dietitian, and I just moved into the role as coordinator last year. So I get to coordinate our expanding team of professionals, and we have a really experienced team.
How many on the team?
Everybody who touches our patients, it's probably 40 or 50 people.
Okay.
We convene every other month and talk about all of our program and processes. But
So it's like a workshop that happens after the surgery. You guys get together to discuss individual patient progress or success?
we do that.
Okay.
So our program, I'll kind of start you off from the
Please.
beginning. Someone's interested in surgery, first needs to know who would be a candidate for surgery. So when we're talking about bariatric surgery, we're talking about weight loss surgery. There's several different options. At MUSC currently, we do the gastric bypass, the sleeve gastrectomy, the biliopancreatic with duodenal switch, which
Okay.
we call the switch,
How long
because
did-
that's a mouthful.
How long did it take you to be able to articulate that one?
Less time than you would think.
Okay, all right.
So then we also are starting to do a new procedure that's not a surgical procedure, the intragastric balloon. So we're expanding. Innovative technologies and new procedures
So
come out all the
basically,
time.
It's 4 procedures that are available.
The main 3 procedures that are surgical and the 1 non-surgical that'll be, up and coming.
Okay.
So the surgery program begins with patients being interested in weight loss. Candidates for surgery tend to be about 100 pounds over what someone calls their ideal weight. And if you know about body mass index, their body mass index is either over 40 or over 35 if they have health conditions. And so that would mean, they're carrying an extra 100 pounds or so and unable to lose it with other means.
The health condition that we're talking about, one of the primaries is diabetes.
Diabetes is a big one. We
Uh-huh.
have about 35% of our patients have diabetes when they have surgery, very few afterwards.
That's exactly right.
High
And
blood pressure in about half of our patients.
We've had the pleasure of talking to Dr. Frenga, who does the gastric bypass surgery down in Orangeburg.
Okay.
And it was amazing to us, and it's been amazing to our audience to tell them that people walk in surgery with diabetes and they walk out without it.
Yeah, that's the number one thing patients talk about in our support group that we have every month is just how happy they are to be off medication and insulin. And, one of the other exciting things that's sort of new in the field is all of the diabetes organizations really joining on board to say this is not just weight loss surgery, they call it metabolic surgery because it really does change the metabolic pathway and it really does help with diabetes resolution in a great majority of patients. So that has been a really nice support to have all of the organizations supporting surgery for those who are heavy and those who have diabetes.
As a dietitian, talk to us about, from that aspect, what's important that people need to know.
Sure.
And those who, how do you avoid becoming obese? Obesity is really what the issue is.
So that's a loaded question.
I know.
I'll try to tackle it. So for patients who are not overweight yet, that's a whole different group of patients. And I think one of the big issues in our field is the bias that people have towards patients who have obesity. And so even from providers and other people I talk to who would say, oh, that person's 100 pounds overweight, well, why don't they just exercise? Why don't they just try this and that fad diet? The reality is once someone's carrying 100 or more pounds on their frame, they could have a great diet. I have patients who come in every day who eat better than I do. But once you're metabolically different from carrying that extra weight, you could do any means and really not be able to lose weight. I have patients who have lost and gained weight several times before. And if you look at even any of this new literature from the Biggest Loser, there's been some articles coming out about patients who've lost an extreme amount of weight. Once they get down to that lower weight, they need so few calories to maintain that it's not attainable with a normal means. So I always, I talk to patients about that. The only way that someone can really survive on, under 1,000 calories a day would really be if your stomach is that small.
Okay.
And so for surgery patients, that's attainable.
And that's what the surgery actually does.
Right. So so the surgery really operates with a couple different mechanisms. Some version of restriction, making the stomach smaller, malabsorption, or
Is that when you talk about the sleeve?
So pretty much all bariatric surgeries make your stomach in a way smaller. The gastric bypass makes it smaller, where they divide the top part of the stomach away from the bottom part and reconnect the small intestine, so the pathway is different.
Let's do that again. Let's do it again, because as you're talking, there's an illustration which is actually showing that process. So
the gastric bypass, the mechanism there is restriction and a version of not full absorption of the nutrients. So the surgeons will take the top part of the stomach and surgically divide it from the bottom part.
So you're actually cutting the stomach in half.
Yep. Okay. And then if you just did that, you'd have one meal and be full forever. So they cut the small intestine.
They'll cut the stomach in half, and they'll sew it back together.
Yep. And then they'll reattach the small intestine to the bottom of that little stomach pouch. So the food will come through the mouth, down the esophagus, will sit in that small pouch, and then after a little while will come through the small intestine. So patients will eat solid food. They'll chew their food, swallow it, it'll sit here for a while. Foods that are liquidy will go down faster. So, part of the program is really focusing on those solid foods that will keep you fuller longer. And you'd be so surprised how many patients would be full on 2 or 3 bites of food. You're sitting next to them at a restaurant and they're done, and waitresses will ask, oh, is the food not good? They're like, no, I'm stuffed. So it's a really nice way to feel physically full, whereas when patients are on that diet roller coaster, they're just restricting their intake because someone told them to, but they're not feeling full. So the fullness that patients have after surgery is probably the best part of learning how much it takes to get full and stop. I'll tell you a little bit about the sleeve, which has a different mechanism. The sleeve takes the stomach vertically. It's called the vertical sleeve gastrectomy, long ways, and cuts on the inner curvature of the stomach and makes it so that your stomach is very long and skinny without that bigger part. That part gets removed and thrown away. And with it goes a lot of the appetite hormones. So patients will have a much lower appetite after both procedures.
So one is restricting the amount, and one is psychologically lowering your desire.
They overlap. So both have that component of smaller stomach, full on a small amount of food. The absorption component and the appetite component comes in with both a little bit differently. So the sleeve takes away most of those appetite hormones right away. There's a smaller part of the stomach which is still exposed to stomach acid, and that will be how you digest your food. Whereas the gastric bypass, you're dividing it at the very top and your pouch is a little bit higher up. You don't have very much stomach acid, which is why some people call it an anti-reflux surgery. But
so persons who do have the surgery, if they've had any acid reflux, would not experience it again.
They're even calling for gastric bypass to be an anti-reflux surgery in people who do not have obesity.
Interesting.
So that's a very big benefit for patients.
We're here at MUSC, and we're talking with Nina Crowley, and we're talking about gastric bypass surgery. How many of these procedures do we have during the course of a month, let's say?
So right now we have at MUSC, we have 2 primary surgeons, Dr. Byrne, who's been with the program for 25 years. He started the program back in the day when it wasn't even very well known, and Dr. Rana Palat, who joined us about 10 years ago after doing his training here. We've also recently added Dr. Lesher, who's an adolescent surgeon, when we've had our adolescent program.
Adolescent obesity.
Right. So there
are numbers there as well?
Big numbers of obesity, less patients who come through, so I can tell you about that too.
Is a lot of it regional because of South Carolina, because of the diet?
Not at all.
It's not?
It's everywhere. I know you and I are from New York, and so they're not immune up there. You're not immune who you are, income, and none of that. It's all over the place, which is why surgery for the people who are at the extreme end of that is really effective. And I think talking about procedure types and all of that is a way to educate folks, but another way is really to educate their providers. I feel that in surgery, people have such a bias towards surgery being scary and people don't want to have it. So the statistics are actually pretty wild. Only 1% of patients who qualify have weight loss surgery.
Wow.
And we're talking, 2/3 of our state is overweight and obese, about 1/3 is obese, and then after that, you're talking about the morbid obesity with your body mass index over 40. Much fewer patients have surgery who are candidates.
And they really need it.
Yeah, and they also show that one of the best predictors for who would consider surgery is having the recommendation from your healthcare team. And so I think one of my biggest goals is to educate providers to recommend surgery for patients who are qualified.
So it should be a multi-pronged approach. Doctors at every level,
Right.
even if it's a doctor who deals with rheumatoid arthritis,
Yeah.
and if somebody has an obesity as an issue as well,
Right.
that they should be recommended for at least exploring a
Right.
surgery that would enable them to have gastric bypass surgery.
Right. So I think the responsibility for the recommendation is a really big part of it
Nurse
because
practitioner,
yeah.
dietitian, everybody who sees it
Right.
might suggest or say,
Right.
this might be an alternative for you,
Right.
an option for you.
So I think patients are often waiting for the doctor to have that conversation or waiting for their provider at any
Well,
level.
then should most providers be educated about the value of gastric bypass surgery?
Absolutely.
Okay.
So I think the part of surgery that's such an interesting bias that people have so many values about and ethics, it's not considered as the same way as you would with blood pressure, right? So you come in with high blood pressure, you get treatment, you staged approach, right? One medication. How is that working? Two medications, right? With weight loss and weight loss surgery in particular, it's well, why don't you just try why don't you just do this?
But here's the thing. If everybody begins to lose weight and some of those morbidities begin to decrease, some of those doctors might not have a job.
The post-op management is still there.
Ladies and gentlemen, we're here at MUSC. Thank you very much.